Hi, everyone. My name is Lillian Marokian. I am a primary care physician at the Fish Center for Women's Health at the Brigham and Women's Hospital. And my talk today is Women's Health Take-Home Messages. So I have no disclosures. And today I will be summarizing and highlighting the take-home messages in each of these 6 topics presented in the Women's Health section of this review course. So topic number 1 is menstrual irregularities and amenorrhea. So primary amenorrhea, so this is the absence of menses by the age of 16. Secondary amenorrhea is the absence of menses for at least 3 months in women who have had normal menarche. For primary amenorrhea, there's a higher incidence of genetic and anatomic abnormalities. For secondary amenorrhea, hypothalamic causes account for about 36%, and second to that is PCOS at 30%. General etiologies include pregnancy, uterine outflow tract disorders, and ovulatory disorders. And evaluation, so labs to think about include beta-HCG, FSH, prolactin, and TSH. So the other thing to think about here is, does this patient need a brain MRI as part of their evaluation? And the answer is yes, if they have primary amenorrhea, if they have headache, or an elevated prolactin level. And the other is bone density. So in which patients who have amenorrhea do we obtain a bone density? And this is in patients who have more than 6 months of amenorrhea. So hypothalamic amenorrhea. So the etiologies here are women who are excess exercisers, have had a lot of weight loss, are under a lot of stress, both either psychological or physical, eating disorder patients. And in general, it is energy output is greater than energy input. Treatment really targets the etiology of their amenorrhea. So it's, having them gain weight, having them reduce exercise. And then really giving back estrogen to these women, so in the form of oral contraceptives or hormone replacement therapy. Calcium and vitamin D supports bone health. So primary ovarian insufficiency. So this is a woman or a patient with amenorrhea who is under the age of 40, and you check an FSH and it is very elevated. So the etiologies of POI are in several. So genetic etiologies, autoimmune etiologies, and then as a consequence of chemo or radiation therapy. So diagnostics really are dependent on what you think the cause is. So karyotype if you're suspecting Turner's, and then you can do Fragile X premutation screens for patients who you suspect Fragile X, antithyroid or anti-adrenal antibodies for autoimmune causes. And the mainstay of therapy in these women is hormone replacement therapy. So that or oral contraceptives, and again, supporting bone health with calcium and vitamin D. So PCOS, so polycystic ovarian syndrome. So about 4.7 to 6.8 patients, sorry, can I do this? Let me start one more.
Okay.
So PCOS, polycystic ovarian syndrome. So 5 to 7% of women have PCOS. It is the most common cause of female infertility, accounting for 50 to 60%. It is the most common endocrinopathy in young women. And how do we diagnose PCOS? So there's 2 definitions, NIH and Rotterdam. For NIH, you want to have all of the following. So oligomenorrhea at less than 9 menses per year, hyperandrogenism, either clinical or biochemical, and then exclusion of other diseases as I've listed. And Rotterdam is 2 of the 3 that are listed below. So again, oligo or amenorrhea, hyperandrogenism, and polycystic ovaries seen on ultrasound. So for treatment, this really targets the clinical manifestations. So weight loss for these patients, definitely. Hormonal therapy like birth control pills or progesterone to treat or prevent the prolonged anovulation in these women. spironolactone or laser hair removal for the hirsutism, metformin for insulin resistance, also, for insulin resistance, encouraging weight loss, and also evaluating these patients with insulin resistance, checking blood pressure and their lipid panels. For the infertility, a referral to GYN or reproductive endocrinology. Okay, so next topic is contraception. So this chart outlines the failure rate of various types of contraception. This is the failure rate in 1 year, and it compares typical use and perfect use. So most notable here is the types outlined in yellow, which includes the barrier methods, hormonal contraception, including pill, patch, and ring. And the effectiveness of these methods really depends on correct and consistent use. As you can see that the typical use failure rates in these patients are much higher than perfect use. And in contrast, in green, we have IUDs and Nexplanon, and really the failure rates are comparable because these are not user dependent. So more on IUDs. And this is a list really of the benefits of IUDs and supports why IUDs have come into favor. So IUDs are immediately effective and the patient can forget about it. They have a high patient satisfaction rate. It is available for women of all reproductive ages, regardless of parity. You can use IUDs in women who have hypertension, who have complicated migraines. So in those patients, we're not able to use combined hormonal contraception, but we can consider the hormonal or non-hormonal IUDs or Nexplanon. IUDs are the first line in adolescence. They can be inserted immediately after an abortion, a miscarriage, or a vaginal delivery. And copper T can be used as emergency contraception. So if it's inserted within 5 days of unprotected intercourse, it can be used as emergency contraception. The other notable piece here is that upon removal of IUDs, you have a rapid return to fertility. And so this is important and is in contrast to oral contraceptives or, let's say, the Depo-Provera injection. So this chart is the types of IUDs, and I've tried to kind of organize it into hormonal and non-hormonal. So obviously at the top is the copper T, which is non-hormonal. It lasts for 10 to 12 years. Failure rates listed at 8 to 12 years, so about 2%. And then in green are the hormonal IUDs that are now available, and they're in kind of decreasing total hormone content. And I've listed the total content and as well the average amount of hormones secreted per day. So Mirena and Lolita you can use for about 5 to 7 years. Kyleena also has a much lower dose, but can be used up to 5 years, and Skyla up to 3 years. Some notes about these IUDs. So the copper T, as it is non-hormonal, you definitely have more bleeding and cramping compared to hormonal IUDs. Hormonal IUDs have a higher chance of amenorrhea with the higher doses. So Mirena, Lolita will more likely result in amenorrhea compared to Kyleena and Skyla. And then in these hormonal IUDs, 10% of women will complain of changes in mood, acne, headache, or breast pain. But these do not cause weight gain. All right, and some things to consider. So when do we start contraception? So this is any time in the menstrual cycle if you are reasonably certain that the patient is not pregnant. So what does reasonable certainty mean? This means that it is within 7 days from the start of their menstrual cycle. They've not had any intercourse since the last menses, or they're using another reliable form of contraception, and you're switching, let's say, from the pill to the IUD. The other piece here is contraindication. So for combined hormonal contraception, pill, patch, and ring, because these are estrogen containing, it is contraindicated in patients who have hypertension, patients who have cardiovascular disease, smokers over the age of 35, and patients who have complicated migraines. So not classic migraines, but migraines with aura. All of these conditions pose a risk to the patient. And then for IUDs, obviously, we're not putting them in a patient who has a current pregnancy, who has current PID, who has an untreated STI, or, of course, patients with cervical cancer, breast cancer, or other uterine anatomic anomalies. Okay, so the next topic is HPV. So some basics on HPV. It is the most common STI in adolescents. It's very common in general, so there's a 79 to 85% lifetime risk of having HPV. High-risk HPV has a high clearance rate, so this is good news. So 80% of patients will clear HPV in 12 months, and 95% of patients in 3 years. And we now know that almost all cervical cancer is caused by HPV. There are 45 mucosal and genital subtypes, and we divide these into high risk and low risk. So I've listed some of the high risk. This certainly is not a comprehensive list of the high risk HPVs, and these are the ones that cause abnormal pap smear, cervical cancer, anogenital cancer, and oropharyngeal cancer. Low risk HPV are non-oncogenic. So this, for example, is subtypes 6 and 11. So these are associated with genital warts and laryngeal papillomas. Okay, so now we are vaccinating a lot of our young patients, or hopefully most of our young patients, for HPV. So this is a routine vaccination in males and females ages 9 to 26. If you're considering it above the age of 26, this is a discussion that you would have with your patient. There are a few types of HPV vaccine, but we're now using Gardasil 9, which has been available in the US since 2017, and is a 9-valent vaccine. Dosing schedules depend on the age of the patient. So if you're starting in patients under the age of 15, it's 2 doses. And over the age of 15, it is 3 doses. And also, you can consider this obviously in immunocompromised patients at any age, and that would be a 3-dose regimen. Side effects, highest thing is 24% of patients will report local injection site redness and swelling, 10% fever. So cervical cancer screening. So we start screening our patients at age 21. And between the ages of 21 and 29, we're doing pap smears every 3 years if they're normal. We do not do routine HPV screening in this age group because HPV is so prevalent and clears readily. So we're only doing reflex testing for patients that have ASCUS, or atypical squamous cells of undetermined significance. In our women over the age of 30 and up to 65, we're doing co-testing. So it is cytology and HPV co-testing, and if normal, we can go every 5 years. If you're doing cytology alone, then you go every 3 years. There is an HPV alone test called COBRIS, which you can do every 3 years, and this is in patients over the age of 25. So our high-risk patients, we screen them more frequently. And who qualifies for high risk? So these are patients who have a history of CIN2 or 3 or cervical cancer. And they need sort of regular screening for 20 years from the date of diagnosis. Other patients in this category include patients who had in utero exposure to DES, who are immunocompromised or HIV positive. And then when do we stop? So we can stop pap smear screening at the age of 65 if we have had 3 consecutive negative cytologies or 2 negative cytologies with negative HPV co-testing within the prior 10 years. And of course, the last screen needs to occur within 5 years of stopping. You can also stop in your patients who've had a hysterectomy with their cervix removed for benign disease. But if they have had a hysterectomy for CIN 2 or 3, then you're going to be continuing pap smear screening as noted above. Okay, so what about management of abnormal pap smear? So in this case, we have a 30-year-old female who presents for routine pap smear screening. The results state unsatisfactory cytology and HPV co-testing is negative. So what do you do next? What is the next step? So we can use this app, so the ASCCP app for management. You can also use it for screening guidelines. So in this case, we would select management guidelines. We go to the next screen, and then we put in the key demographics, so the age of the patient, HPV status, pregnancy, and then the results. So you select here unsatisfactory, and then move to the next screen, which then gives you your recommendation. And so in this patient, we would need to have her return in 2 to 4 months for repeat cytology. Okay, so next topic is medical complications of pregnancy. So hypertension. So some definitions. Pre-existing hypertension is hypertension in your patients before 20 weeks gestation. Gestational hypertension, in contrast, begins after 20 weeks. So elevated blood pressure after 20 weeks gestation and without signs of preeclampsia. So preeclampsia is hypertension after 20 weeks, but also has proteinuria or other end organ manifestations. And then superimposed preeclampsia is preeclampsia that begins in your patient who has preexisting hypertension. The risk of this is if your hypertensive patient has been hypertensive for greater than 4 years or has not had well-controlled blood pressure, so diastolics greater than 100. So for blood pressure goals are higher in our pregnant patients than in our non-pregnant patients. And so for systolic blood pressure goals, your target is 120 to 160, and diastolic is 80 to 110. For treatment, you definitely want to stop ACE inhibitors and angiotensin receptor blockers in your patients with pre-existing hypertension prior to conception due to fetal risk. When you are treating a pregnant patient for hypertension, first-line therapy is the alpha blockers or calcium channel blockers. So labetalol is very commonly used, and nifedipine. Methyl-dopa used to be used and now is less favored due to efficacy and side effect issues. Okay, so diabetes. So diabetes in our pregnant patients. So the take-home message here is that preconception counseling in your patients with pre-existing diabetes is essential for good outcomes. We want to normalize their A1C prior to conception because birth defect risk is directly related to their A1C at conception. So talking about preconception glucose control and reviewing with them that this reduces birth defects. So goals of therapy are A1Cs less than 6.5%. In your patients who develop diabetes or have diabetes during pregnancy, I've listed some of the blood glucose goals. So your fasting blood sugar should be less than 95, postprandial 1 hour less than 140, and then 2 hours less than 120. And A1C goals are similar, so less than 6% if that's achievable without too much hypoglycemia. For treatment, and particularly in gestational diabetes, diet and glucose monitoring is the mainstay. In our patients with pre-existing diabetes, if they are on other agents other than insulin, you want to change them to insulin. As they are pregnant, keep in mind that insulin resistance increases as the pregnancy progresses. So their insulin requirements will increase during pregnancy. And in general, I've listed the different insulin types, long-acting, short-acting, and pumps that are used in our pregnant patients. A side note on gestational diabetes. So this, again, is diabetes that is first diagnosed during pregnancy and resolves with delivery. Keep in mind that the future risk of type 2 diabetes in these patients is very high, so upwards of 60 to 70%. So these patients need to be regularly screened throughout their life. Okay, so hypothyroidism in pregnancy. So essentially, the goals of TSH in these patients is a TSH below 2.5. So at conception and then during their pregnancy, roughly less than 2.5 or 3 is the goal. And for treatment, keep in mind that thyroid hormone requirements increase during pregnancy and then return to pre-pregnancy requirements postpartum. So at delivery, you can reduce their thyroid hormone dose to pre-pregnancy levels and then monitor their TSH and recheck it in 6 weeks. Okay. So next topic is osteoporosis. So who do we screen? So general guidelines are we screen all women over the age of 65. We screen men over the age of 70 who do not have any risk factors for osteoporosis. If they have risk factors, then we're screening them earlier. Postmenopausal women who are under the age of 65, so between 50 and 65, and you find that they have risk factors for osteoporosis, you're going to screen them earlier. And any patient who has a fragility fracture should be screened. The FRAX calculator is another tool to assess their risk of fracture or risk of osteoporosis. So this calculator assesses their 10-year risk of major osteoporotic fracture and hip fractures. The limitation of the FRAX calculator is that it underestimates the risk of fracture at the lumbosacral spine as it uses the femoral neck bone density in its calculation. Also, it underestimates the risk in patients who are on chronic high-dose steroids. So you can adjust the FRAX by 15% for major osteoporotic risk and by 20% for hip risk in patients on high-dose chronic steroids. So treatment, who do we consider medication treatment for? So patients with either vertebral or hip fractures, patients on DEXA who have their T-scores minus 2.5 or lower, so upwards of negative 2.5 at the lumbar spine, femoral neck, or total hip. If your patient has osteopenia on DEXA, but their FRAX score is their 10-year probability of a major fracture is greater than 20%, or hip fracture greater than 3%, this is an indication to start medication treatment. Other high-risk conditions are a patient who's had a recent fracture, and recent means within 2 years, or if they've had a wrist or humeral fracture. Keep in mind, a Colles fracture is considered a fragility fracture. And then, of course, patients on steroids, as they have a high risk within the first 6 to 12 months of use. So treatment, so non-pharmacologic treatment for osteoporosis. So this is targeting lifestyle. So it is stopping smoking, reduction in alcohol use, counseling patients on weight-bearing exercises and muscle strengthening exercises. Adequate vitamin D and calcium. So vitamin D daily, somewhere between 800 and 1200 IUs, with a goal vitamin D level of greater than 30 nanograms per milliliter. Calcium in diet, so this is your daily dietary recommendations, and counsel patients for supplements only if they're not getting enough calcium in their diet. For pharmacologic agents, so I've divided this between anti-resorptives and anabolics. So anti-resorptives, so bisphosphonates come in oral and IV. So the oral bisphosphonates, and specifically alendronate and risedronate, reduce vertebral, hip, and non-vertebral fractures. The IV zoledronate or reclass reduces hip and vertebral fractures, but not non-vertebral fractures. Raloxifene, which is a SERM, is second line. It has some data on reduction of vertebral fractures. You can think of this in your patients who are younger, who have a family history of breast cancer, as this does also reduce the risk of ER-positive breast cancer. You can use it for years, and to keep in mind, there is a slight increased risk of VTE and stroke. So the next agent is denosumab or Prolia, and this is a very effective agent. It's reducing vertebral, hip, and non-vertebral fractures. And notably, you can use this in your patients who have chronic kidney disease. Things to keep in mind if using Prolia, there is a slight increased risk of infections, including cellulitis and erysipelas. Also, you cannot abruptly stop this medication as there's a rapid loss of bone density. So you can transition to another medication, but you cannot abruptly stop it. Anabolics, an example would be teriparatide. This has a side effect of causing osteosarcoma in rats. You can consider these agents with endocrine consultation and when your anti-resorptive agents are ineffective. Okay, a little bit more on bisphosphonates. So again, as I mentioned, there are oral bisphosphonates and IV. So the oral bisphosphonates we're using for about 5 years, and it can be used for longer as long as you're monitoring the patient, as long as they need it or continue to need the agent. For IV zoledronate, it's an annual infusion once a year for 3 years. Regarding stopping or drug holidays, so if you're monitoring your patients and they're improving and they remain low to moderate risk, you can consider stopping the drug and then continue to monitor them. Side effects or contraindications in bisphosphonates. So you cannot use bisphosphonates in patients with CKD, so a GFR less than 35. They do cause, so the oral bisphosphonates cause GI irritation, so keep that in mind. And the IV infusion causes, in some patients, a flu-like reaction. This is minimal, it is short-lived, and you can pre-treat with NSAIDs in some cases. So other side effects that have gotten a lot of press is ONJ and atypical femur fractures. So for osteonecrosis of the jaw, this is very rare, but we still need to make sure our patients have a dental checkup prior to starting bisphosphonates. And if your patient is planning an implant or extraction, then you want to delay the start of the medication until they are done. Atypical femur fractures, really in patients who have used less than 5 years of bisphosphonate, the risk is very low. So I think less than 1%. And also prior to the fracture, 70% of patients will have an aching sensation in the upper femur. So always screening your patients who are on bisphosphonates for this symptom. Okay, so next is menopause. Some definitions and symptoms. And so for age of onset, natural menopause is that which occurs in a woman over the age of 45. So menopause over the age of 45. And in the US, the average age is about 51 and a half. Early menopause is menopause that occurs in your patient between the ages of 40 and 45. And then, as we spoke about earlier, primary ovarian insufficiency is menopause that occurs before the age of 40. There's also surgical menopause to consider. Symptoms, very common, 70 to 80% of women will report symptoms. I've kind of listed them between genitourinary symptoms and vasomotor symptoms. So for GSM, this is a chronic and progressive condition without treatment. It encompasses the changes in the vagina, vulva, and bladder during menopause and results in vaginal dryness, dyspareunia, decreased lubrication, and then a lot of urinary symptoms, including dysuria, stress urinary incontinence, and recurrent UTI. Vasomotor symptoms obviously are hot flashes, night sweats, and as a consequence, poor sleep. So a little bit more on management, and so management of the genitourinary syndrome of menopause. Really, the most effective thing here is vaginal estrogen. So vaginal estrogen comes in the form of cream and rings and inserts. The vaginal estrogen is safe and effective. We are not seeing any increased risk of breast cancer, cardiovascular disease, or DVT-PE. And a note on our breast cancer patients. So non-hormonal options remain first line. You can discuss with the breast oncologist regarding the safety or possibility of using vaginal estrogens, but really you want to exhaust the non-hormonal options first. So those include lubricants and moisturizers, pelvic floor PT for stress urinary incontinence, dilators. There is ospemifene, which is a SERM that was approved for treatment of dyspareunia, but does have some reported side effects. Vaginal laser and radiofrequency ablation is a bit newer, and then vaginal DHEA. So management of vasomotor symptoms. So here you're going to counsel your patient on lifestyle management. So this includes diet, weight control, regular exercise, avoiding tobacco use, reduction in alcohol use, keeping cool. A lot of patients ask about phytoestrogens. Generally, these have been shown to be ineffective in randomized controlled trials. For non-hormonal treatment of hot flashes, you can use SSRIs, SNRIs, gabapentin, oxybutynin, or clonidine. So SSRIs, the only FDA approved one is paroxetine at 7.5 milligrams that your patient would take at nighttime, and this is known as Bristol. You can use any of the other SSRIs, but keep in mind that they can impact the effectiveness of tamoxifen. So in your patients who have breast cancer or suffering from hot flashes or on tamoxifen, you might want to talk to them about other agents first. So for example, SNRIs like venlafaxine and desvenlafaxine can be used for hot flashes, as well as gabapentin. And a note on postmenopausal hormone therapy. So this definitely improves vasomotor symptoms. And the general guidelines here are to use postmenopausal hormone therapy at the lowest effective dose, and generally not more than 5 years, though in some cases longer might be okay. The Women's Health Initiative showed an increased risk of CHD, stroke, and invasive breast cancer in women on hormone therapy, yet also a reduced risk of fracture and colorectal cancer. So when thinking about postmenopausal hormone therapy in your patients with hot flashes or vasomotor symptoms, you would not be prescribing this in patients with a history of VTE, breast cancer, cardiovascular disease, liver disease, or endometrial cancer. Okay, so this concludes my talk today, and I thank you for your attention.